90% of HIV-infected pregnant women should adhere to all the steps of the cascade. However, in 2010, only 35% of pregnant women from low and middle-income countries were tested for HIV, and 53% of women identify as being HIV positive, and 42% of HIV-exposed infants receive antiretroviral prophylaxis. So this indicates that there is a need for alternative strategy if we want to achieve the goal of a generation free of HIV. Such a strategy will include immune-based intervention. Immune-based intervention can comprise a maternal vaccine, and a maternal vaccination can reduce the plasma and breast milk virus load, which is important because it has been associated with increased risk of transmission. And maternal immunization can also passively immunize infants because maternal antibodies are transferred to the infant. Another way to passively immunize infants can be through the administration of broadly neutralizing monoclonal antibodies. And next Tuesday, there will be a chat talk that Dr. Cunningham will lead, discussing this strategy, and everyone interested should attend the talk. And finally, another way to protect infants would be through infant vaccination that can protect from postnatal HIV acquisition. Why are we studying an infant vaccine is because it is unclear if HIV vaccination will induce similar responses in infant and adult due to the differences in their immune system. Notably, the immune system of infant is immature, and infants have maternal antibodies that can block or inhibit B-cell responses in infants. Interestingly, in the RV144 adult trial that showed moderate protection, immune correlates have been identified. These are anti-V1, V2 IgG antibodies that were associated with a decreased risk of HIV acquisition, and anti-envelope specific IgE antibodies that were associated with an increased risk of infection. To date, there haven't been any efficacy trial conducted in infants, but the identification of these immune correlates give the opportunity to look at which type of response were elicited in previous pediatric trial conducted in infants, and to investigate if infant vaccination can induce potentially protective immune responses. And this was the goal of this study, where we look at two previously completed phase 1 pediatric vaccine trials, PAC 230 and PAC 326. So in PAC 230, both of these studies were US-based studies, and in PAC 230, the infant received 4 doses of vaccine between 0 and 20 weeks. The vaccine was either a recombinant GP120 from the SF2 strain administered with MF59 as the adjuvant, and that is the Chiron vaccine, or a recombinant GP120 from the MN strain administered with alum as the adjuvant, and that was the VaxGen vaccine. The PAC 326 vaccine was a small study with only about 20 infants, and this study used a vaccine strategy very similar to the one used in RV144. It was a pox prime protein boost vaccine regimen, and the vaccine was administered between 0 and 12 weeks of age. So the first response we looked at was a response elicited against an antigen that was not included in the vaccine, and we used GP41 for this purpose. On this slide and in subsequent slides, the black will represent Chiron vaccinase, red VaxGen vaccinase, green placebos, blue Alvac EdVac vaccinase, and purple placebo from the 326 study. As you can see on this, as you can see here, the decline of the response was very similar in all the vaccine groups, and at week 52, most of the infants no longer had detectable antibodies, indicating that most of the maternal antibodies are waned by week 52. Forgot to mention that on this slide and in subsequent slide, the dashed line represents the positivity cutoff. We next look at the response, again, one of the vaccine strain envelope during the first 2 years of life. And the most interesting finding that we had was with the Chiron group, where we found that at 2 years of age, more than 50% of the infants still had vaccine-elicited antibodies. And this is important because ideally a pediatric vaccine should protect throughout the period of breastfeeding, so during 18 to 24 months. We look at the breadth of the response at week 52 using a panel of envelope construct from different clades, and we found that most of the infants from the Chiron and the VaxGen group had an antibody response against all the constructs that we tested. A low level of response were observed in the Alvac HVAC vaccinase, but I want to point out again that these infants received their last dose of vaccine 2 months earlier than the other groups of infants, which could contribute to explain these differences. We then focus on the V1-V2 response, the response that was associated with reduced risk of HIV acquisition in RV144. On this slide, the left panel represents the magnitude of the response and the right panel the frequency of the response. Looking at the magnitude, you can see that at week 24, we have a high level of V1-V2 IgG antibodies, especially in Chiron vaccinase. And interestingly, we also find that at this time point, most of the placebo no longer have a response. The magnitude of the response is very low in placebos. At week 52, we still find a high level of anti-V1-V2 antibodies in Chiron vaccinase. Now, looking at the frequency of the response, this is confirmed as we found that 98% of infants vaccinated with the Chiron regimen had anti-V1-V2 antibodies at week 24, and at week 52, more than 6 months after they received the last dose of vaccine, 93% of the infants still had anti-V1-V2 antibodies. We'd like to mention that the antigen that we use to look at this response is the same antigen that was used in the immune correlate analysis of RV144, and in the adult vaccine study, 64% of the vaccinees had this response. We further characterize the V1-V2 IgG response by looking at the concentration of antibodies in the plasma of vaccinated infant, and we focused this only on the Chiron regimen because that's the one that gave the highest level of response. The left panel shows the response in placebo, the right panel shows the response in Chiron vaccinase, and the table at the bottom of the slide shows the median concentration of V1-V2 antibodies in Chiron vaccinase at week 24, week 52, and the concentration of antibodies in RV144 adult vaccinase at peak immunogenicity. And you can see that at week 24, the concentration of V1-V2 IgG is more than 20-fold higher than at peak immunogenicity in adult vaccinase. We then look at the isotype of the V1-V2 response, and we specifically look at IgG1 and IgG3. Most of the infants had anti-V1-V2 IgG1 antibodies, but interestingly, we also find that about 50% of the infants had IgG3 antibodies. And finally, we looked at the envelope-specific IgA antibody response because this response was associated with an increased risk of HIV acquisition in the RV144 trial, and we didn't find any vaccine-elicited IgA antibodies in infants. So on this slide, the line represents the positivity cutoff of, and all what we measure was below the cutoff. To make sure that this was not due to our assay, we look at the response in the few infants that were infected in these studies, and we were able to detect IgA antibodies. So in conclusion, in this study, we found that HIV infant vaccination can induce strong anti-HIV envelope IgG responses, including anti-V1-V2 IgG1 and IgG3 antibodies. The Chiron vaccine regimen, which was a recombinant GP120 vaccine administered with MF59, induced long-lasting responses in infant and higher concentration of V1-V2 IgG antibodies than in adult vaccinase. So these data are not, the story is not complete. We still have ongoing studies, but based on this preliminary result, there is a suggestion that an infant vaccine can be at least as potent as an adult vaccine. I would like to acknowledge all the people who contributed to the study. For the sake of time, I'm not going to go through the slide, but I would like to especially acknowledge CFAR for providing the funding for this study. Thank you.